invite you to the podium. Please speak loudly, and looking forward to your presentation. Thank you.
Thank you, Dr. Stock, for the introduction, and to the committee for the opportunity to present. Today, I'll share with you some genetic findings we have found that associate with the development of osteonecrosis in children under the age of 10 being treated for ALL. Osteonecrosis has become a limiting toxicity for ALL, or acute lymphoblastic leukemia, the most common signal malignancy in childhood. Despite intensification of therapy, or because of intensification of therapy, we've been able to improve outcomes for children with ALL over the last several years. However, osteonecrosis has limited that therapy. It's characterized by the destruction of the normal bone due to localized tissue death. It is most frequently seen in the weight-bearing joints of the hips, knees, and ankles. Osteonecrosis results in pain and ultimately decreased mobility, and treatment for it can involve surgery, including up to and including joint replacement. Recent pediatric ALL trials have required amendments to try to decrease the rates of osteonecrosis, and this has prevented us from using more intensive regimens involving steroids and asparaginase, drugs that have some acute toxicities but have fewer long-term side effects than many of our other alternatives. Collaborative research between St. Jude Children's Research Hospital and the Children's Oncology Group has sought to identify the genetic risk factors for the development of osteonecrosis. However, because of age-related differences, the genetics of osteonecrosis in young children remain incompletely understood. As the slide demonstrates, there's between a 3- and 5-fold increased rate of osteonecrosis for children between the age of 10 and 20 compared to younger children. And this has caused our prior genetic findings to not well evaluate the impact on younger children. However, these children under 10 make up approximately 75% of the new diagnoses of ALL every year. And as a result, despite their lower per-patient incidence, these children under 10 make up approximately 40% of the overall cases of osteonecrosis that occur each year. So there's a clear need to better understand the genetic relationship and the genetic basis of osteonecrosis in these patients. To do this, we performed a genome-wide association study, or GWAS, of children treated on the Children's Oncology Group protocol AALL0331, which is a standard risk protocol. We adjusted our analysis for covariates. We then performed a parallel genome-wide association study in children under 10 treated on the high-risk protocol AALL0232. All of these patients were also enrolled in the biology study 03B1, which Dr. Rates will speak about later. Genetic findings were considered validated if there was an association between a given genetic change and the development of osteonecrosis in both cohorts. And then we sought to further understand what these different variants were doing by clustering them into associated gene groups and genetic pathways, and then also looking at what tissues or cell types these might be affected in by looking at what's called enhancer enrichment. This Manhattan plot shows the results of our genome-wide association study. Variants are arranged by chromosome from chromosome 1 on the left to chromosomes X and Y on the right in the brown. Variants that are shown bolded in are those that are associated with osteonecrosis in both cohorts, while open circles or open triangles demonstrate variants that were associated in one or no cohorts. Top-ranked variants include those in PROX1 antisense RNA1 on the far left on chromosome 1, as well as variants in bone morphogenic protein 7 or BMP7 on chromosome 20. The top non-synonymous variant, the variant that changed a protein structure, was located in the glutamate receptor grid 2. These variants are interesting for several reasons. First, as the name suggests, BMP7, or bone morphogenic protein 7, affects the way that bone is formed, and it affects the change from the precursor cells that ultimately turn into bone. Interestingly, those precursor cells can also turn into fat cells, and so we think the balance between bone and fat within the marrow cavity, which has been shown in animal models to be important for the development of osteonecrosis, may be important in patients as well. PROX1 is a gene where variants in it are associated with familial hyperlipidemia, very high levels of cholesterol in the blood. And so because there is an association between high levels of cholesterol in the blood and the development of osteonecrosis, we think that perhaps this variant may be influencing osteonecrosis risk through its effect on cholesterol levels. Finally, our prior research in patients of all age with high-risk ALL, as well as patients who received glucocorticoids for other reasons, found that glutamate receptors were the most strongly associated variants with the development of osteonecrosis. The finding that our top non-synonymous or our top protein-changing variant was in a glutamate receptor further supports the concept that glutamate receptor signaling and glutamate levels may be important in the development of osteonecrosis in children. When we examine the given biologic pathways that are overrepresented in children with osteonecrosis, we find two key findings. The first is that similar to our prior findings in high-risk patients of all ages, glutamate receptor signaling is the top overrepresented pathway. Indeed, in our younger children, we find that 6 genes are overrepresented in cases of osteonecrosis relative to our controls, including that top non-synonymous variant in grid 2. We also find that the other non-overlapping pathway that's enriched is that of adipogenesis, or the generation of fat from these precursor cells. This includes 7 genes, including our top hit in BMP7, as well as the related gene bone morphogenic protein 2, or BMP2. Finally, we look at which cell types or tissue types these genetic changes seem to be affecting. We find that they're enriched for enhancers, or things that affect how much protein is made, in bone marrow-derived mesenchymal stem cells. These are those precursor cells I mentioned earlier that actually transition into either bone or fat or actually several other tissues based on environmental and genetic cues they're receiving from the environment. So the fact that we're seeing an enrichment in the enhancers of these tissues suggests that indeed the changes within the bone cavity and the bone context between bone and fat may be important in the development of osteonecrosis. In summary, we identified several novel genetic variants that are associated with the osteonecrosis, including those in bone morphogenic protein 7 and the adipogenesis pathway. We also confirmed the importance of the glutamate receptor signaling pathway in the development of osteonecrosis and find some age-related differences, with adipogenesis and BMP7 variants seeming to be more important in young children, whereas individual variants in specific glutamate receptors seem to be more important in the older, higher-risk children that we studied previously. These findings really improve our understanding of the development of osteonecrosis and hopefully will allow further development of biomarkers through preclinical studies, including within our mouse model, that may allow us to develop better cures for osteonecrosis or prevention of this side effect during therapy. Thank you again for the opportunity to